Let's talk further about picking a lead placement and an energy setting for an individual patient. So first, a quick true-false quiz. So the first true-false question is it true that as long as you have elicited an adequate generalized motor seizure at each session, the patient has received an optimally efficacious treatment? The second one is that you could consider this to have been an adequate generalized motor seizure only if the patient has had a seizure that exceeds a predetermined minimum duration, such as 20 to 30 seconds, in motor or EEG activity. The next question is it true that if you increase the energy setting above that necessary to give you an adequate generalized seizure, it really doesn't contribute to either the number of patients who respond to ECT or how quickly they respond, the speed of their response. Rather, all it's going to do is exacerbate cognitive side effects. And finally, the last question is it true that you can just add up the number of seizure seconds for each treatment and that it's meaningful to look at the total number of seizure seconds for the whole, and that there's a certain range of, say, 200 to 1,000 seconds that would be considered a window for a response? Well, the answer to all of these questions is false. It is true that you want to get a generalized motor seizure, and that is necessary. If the patient doesn't seize, it doesn't matter if you stimulated them at 100% energy setting. If they didn't seize, they're unlikely to get well, that the seizure appears to be important in terms of the clinical therapeutic response. But that in itself, you can't simply say that a longer seizure is better, or that if they've had a seizure, that all seizures are the same. If that was the case, you would expect that a just suprathreshold unilateral lead placement would give you just as good efficacy as a higher energy setting unilateral stimulation, or a lower or higher setting bilateral lead stimulation. And yet it turns out there are efficacy differences. So if all that we were trying to do was get a seizure going, that would be a lot simpler. Similarly, let's say you stimulate a person just above the seizure threshold. Right? That person has a slow buildup of their seizure, and then at the end of the seizure it tends to trickle out. Now let's say you give twice that energy. What you'll tend to see is right from the outset a higher amplitude seizure without the big buildup, and that toward the end of the seizure there's an abrupt cutoff. So that seizure with a higher energy setting tends to be shorter than the one with just suprathreshold energy settings. And yet it's more likely to be a more efficacious seizure, the shorter seizure. It was more intense, but it was briefer. So you can't simply say that longer seizures are better. And as I mentioned, low dose unilateral versus high dose unilateral, there appears to be higher efficacy with the high dose unilateral, even if you had two seizures of the same duration. And so two seizures of the same duration may have different efficacy depending on the dose of energy relative to that patient's seizure threshold and depending on the electrical placement. And so here's the original study that brought this issue to light. This is Dr. Harold Sackheim from Columbia, his study that was in the New England Journal of Medicine in 1993. What was the goal of this study? It was really to find the holy grail of ECT, which would be trying to figure out a way to deliver the treatment so that you get maximal efficacy with minimum cognitive side effects. And you would imagine that if all seizures are essentially the same, but that lead placement, where you put the placement of the lead over the brain, might influence cognitive side effects. If we could figure out a placement such as the right non-dominant placement, ideally the right unilateral placement, that kind of puts the electrodes in a safer position, not right over the left temporal lobe. And if we could titrate for each patient at the first session, figure out what is the bare minimum energy that elicits a seizure, that patient's seizure threshold, and just give slightly more than that. So just the lowest possible energy setting using a non-dominant lead placement. It would be great if it turns out that that has equal efficacy to other lead placements and has less cognitive side effects. So this is the protocol that you'll see in most of these ECT studies. You take the total number of patients, let's say you've got 100, and you randomly divide them into half getting right unilateral and half getting a bitemporal lead placement. Then you randomly divide each of these groups. And so in this particular study, what we're doing is we're titrating people. You find out the seizure threshold, and then on the second treatment, in the low dose group, you've got 1.5 times seizure threshold. And in the higher dose group, you go to 2.5 times seizure threshold. And you do the same thing for the bitemporal placement. You got low dose and higher dose. So in this Sackheim study, it was a double-blind study. There were 100 patients, but 4 dropped out. So you've got 96 consecutive patients randomly assigned to unilateral or bilateral patient. Following the initial titration session, you divide them into 2 subgroups, the low dose and the high dose. And then what you do is you have to swoop in right before that first treatment and obtain depression severity scales, a Hamilton depression scale. And you also do some screening testing for cognitive functioning, and you want to get both of these before the course. And now what if one patient only got 6 treatments and one got 8 treatments and another got 12 treatments? When do you reassess their mood and their cognition? So what was done in this study is it was done after the 6th treatment, regardless of how many treatments in the course, and then immediately after the last treatment, and also 2 months after the course of ECT was over. So this also helps you assess whether, let's say, unilateral appeared to do just as well as bilateral, but the improvement doesn't stick as long. So it would be useful to look at people for 2 months after the course is over. And also in terms of cognition, what if the cognitive functioning doesn't last as long with one lead placement versus another? And then what about relapse rates? And so this is much more complicated to do in a study to keep track of patients for a year. But specifically for those patients who were considered to have responded to ECT, they were then followed for 1 year out to assess their rate of relapse. So what did he find? Well, this was a surprise. Right? The surprise is that when you did just suprathreshold, low dose right unilateral ECT, you got what likely was not much more than the placebo response, that you got only a 17% response. If you looked at the 2.5 times threshold unilateral, you got a 40% response. And then for either low or high dose bilateral, you get 65% response. So let's look at it not just in terms of, so response is considered greater than 50% improvement in scores. Let's look at dimensionally the scores themselves. So you can see all 4 groups here at baseline have about, a same score of about, say, 35, which is considered a pretty severe depression score. After the 6th treatment, what you'll notice is that regardless of lead placement, higher energy settings resulted in more rapid improvement. So this is low dose unilateral. This over here, 2 lines down, is higher dose unilateral. In the middle here, we've got the lower dose bilateral, and then over here is the higher dose bilateral. Now what you can also see is that you kind of stall out with the low dose unilateral. There isn't significant further improvement after the 6th treatment. Whereas the same thing here, when you go 2.5 times threshold, things kind of stall out. But with the lower dose bilateral, you see ongoing continued improvement over the course of treatment, right? So it eventually catches up with the higher dose bilateral. Now, what about cognitive functioning? Well, in terms of immediate recovery in the recovery room, the higher dose unilateral group did take almost twice as long to recover orientation post-seizure than the lower dose unilateral, whereas it was even longer than that for the bilateral groups. Now, if we were to look at memory problems, 1 week after the course of treatment was over, there was 3 times more retrograde amnesia about autobiographical information with the bilateral lead placement than unilateral. But 2 months post-treatment, you didn't see a difference between the 2 groups. So this does not answer the question, should you start with unilateral and only switch to bilateral if it's turning out Let's say it does suggest that if you're going to do unilateral, you shouldn't do the just super threshold, that you should do the 2.5, 2 to 3 times threshold unilateral. But it's also a question of how important is that cognitive difficulties 1 week post-treatment compared to saying, well, 2 months later we didn't see this significant difference. What about relapse rates? There was not a difference between the groups in relapse. It was the same for all groups. So if you were fortunate enough to be in the 17% who responded to low-dose unilateral, people remained improved as much as in the other groups. These people might not be placebo responders. They might simply be very exquisite ECT responders. But the relapse rate is still significantly high. What we're talking about is about 6 out of 10 people, 60% of people relapsing over the next year. So here would be the implications that I take away from this study. That if you're using the unilateral lead placement, don't use the very low dose, just super threshold. But if you're using bilateral, you may as well use the low dose, because the low dose bilateral responded as well as the higher dose bilateral. Now that doesn't mean there might not be some people who really do require higher dose bilateral to get a response, but in the aggregate that advantage isn't seen. Now if time was of the essence, you've got a really severely acutely ill patient who's not eating or drinking, you could see the argument for using higher energy settings, since the speed of response was greater in the higher energy setting. I would tend to use a bilateral lead placement if you've got patients who we expect to have a quite high seizure threshold, because what if because of that, even at the maximal settings that the machine can go to, you're not adequately above the seizure threshold using the unilateral lead placement. So patients who are on anticonvulsants or benzodiazepines, patients who just happen to be, say, older males, you may have more difficulty with a unilateral lead placement. Now, there's some remaining questions from that study that subsequent studies have tried to address. And what the questions were after that study was, what should you start with? Should you start with unilateral unless you have more severe circumstances and only switch to bilateral if you're not responding after several treatments? Or should you start with bilateral and only switch to unilateral if a person is having significant cognitive problems? Or if you're particularly worried about cognitive vulnerability or delirium vulnerability, for instance, patients with pre-existing brain disease, elderly patients, stroke patients, Parkinson's patients. The problem with that is that we expect older patients to have higher seizure thresholds, and so it might be harder to obtain an adequate dose for a unilateral lead placement. And also, is this unfair to younger, healthier patients? If we say, I would only reserve unilateral for those patients who are particularly prone to delirium and memory problems, what if it was you coming in to get ECT, and you're, I'm assuming the person listening to this talk is a psychiatry resident or a medical student, would you prefer to get unilateral to minimize the risk of memory problems, even though that might mean you have a lower likelihood of responding? The other question that's not answered is, you've got these groups here. What if we had added a third group here? Let's say we called this medium dose at 2.5, and we call a high dose 6 times seizure threshold. Could we then achieve an efficacy as good as these bilateral groups if we just gave a bit more energy? But if we did get efficacy as good as that, would we maintain any advantage in terms of cognitive side effects? Or at that point, would it basically be a wash when you do unilateral at that high an energy setting in terms of cognitive side effects? Could you get the good without the bad? And that's what a subsequent study by Sackheim looked at. All right, so if we are going to decide that there is a difference between lower doses and higher doses, we do have to decide in an individual patient, how will we pick a stimulus dosage? Obviously, effective dosing requires some ability to either determine or to estimate that particular individual's seizure threshold. And the problem is that seizure threshold varies greatly from person to person. You can have up to a 40-fold variation in seizure threshold between different individuals. And it can also vary from treatment to treatment. Over the course of ECT, the seizure threshold goes up, along with seizure durations tending to go down. Now, I say on this slide, imagine if ECT were a tricyclic antidepressant. And what I mean by that is if you had up to 40-fold variation in tricyclic blood levels between individuals, we'd be really concerned. If some patients ended up with 40 times too high a dose of amitriptyline, those people could have a fatal cardiac arrhythmia. It really is a testament to the overall safety of ECT that some patients can get significantly suprathreshold energy dosing and not have significantly more problems in terms of the overall medical safety of the procedure. Now, why is there such variation in seizure threshold? A lot of this is just endogenous variation in terms of brain firing activity. But there are differences. One, I mentioned that men are very different than women, but other variations include the type of stimulus. I mentioned before that the sine wave stimulus is inherently less efficient than a brief pulse stimulus, so you end up needing higher energy settings and therefore a higher seizure threshold with the sine wave versus what's called partial sine wave, which is where you only have, say, the up but not the down in terms of the climbing and declining of the sine wave, versus brief pulse, which is where we filter out the up and the down and just have that maximal pulse for the pulse. I mentioned just that there could just be endogenous variation. There's also gender, as I just mentioned, that men have higher thresholds than women. They have thicker skulls, which shunts more electricity, and they have a larger neural mass, which decreases current density through the brain. Electrode placement can make a difference, that you have a higher seizure threshold with a bilateral lead placement than unilateral. Again, perhaps because you have a greater amount of cortex in between those two plates to try to stimulate. Age makes a difference, but if we were trying to come up with a ballpark estimate, we wouldn't want to just use age, because if we were to look at the slope of the increase in seizure threshold with age, that slope is much steeper for men and much flatter for women. So if we just used an algorithm based on age, we would end up overdosing older women, where the rise in seizure threshold is not as impressive as with men. Anesthetic agents. The most common anesthetic agent we currently use for ECT is methotrexate, Brevitol, which in lower doses tends to inhibit the brain's inhibitory centers, so it's actually proconvulsant. But at higher doses, it starts acquiring more of an anticonvulsant effect. Other anesthetic agents, so propofol, is a nice drug for ECT because it tends to be relatively smooth and the recovery tends to be pretty smooth. It does also have some sympatholytic effects, which is good, but it tends to cause shorter seizures. Now, that might not be as big a deal if a person would have started out with methotrexate with a 60-second seizure. Maybe the seizure with propofol is 40 seconds. But what about the person who has only a 40-second seizure with methotrexate? It really might be an unacceptably short seizure if it's only, say, 12 seconds with the propofol. Etomidate is another anticonvulsant we sometimes use that has even less anticonvulsant effects, but it has other downsides to it. Not much sympatholytic effect at all, and so you might end up needing to give ancillary drugs like a beta blocker for that spike in blood pressure and pulse you can see. And also, with repeated doses, it also has adrenal suppressive effects on cortisol activity, and that may or may not be clinically relevant. Diagnosis. There's some early research that was done looking at seizure thresholds in different diagnoses, and so it is possible that you might see lower thresholds in mania. People with schizophrenia may, for efficacy, require higher doses of energy. Medications. Drugs like theophylline or caffeine have proconvulsant effects, whereas obviously anticonvulsants, benzodiazepines, have anticonvulsant effects. The ECT itself, I mentioned, over the course of ECT, the seizure threshold goes up and the duration goes down. And that period of time, after 3-4 treatments, that you start really seeing that correlates with when the mood tends to be improving. But that in itself doesn't prove that there is a causal relationship there. Medical conditions. When a person has a spontaneous seizure, they become apneic, and then their CO2 levels climb, and that's one factor about why they stop seizing. So if you have difficulty eliciting a seizure in a patient, you could try somewhat a greater degree of hyperventilation to blow off CO2 and see if that helps elicit a longer seizure or lowers the seizure threshold a bit. In addition to higher levels of CO2, dehydration, which is not uncommon in depressed people who aren't eating or drinking, can also raise your seizure threshold. So you want to try to make sure that patients are adequately hydrated, whether just orally or with some IV fluids if they come into the hospital dehydrated. And then just technique, making sure you've got good contact with the electrode against the skin, that there's not a lot of hair under the plates, that you rub away any dead skin with an alcohol swab if necessary, or makeup that might be there, using enough conducting jelly, or having adequate stickiness of the sticky pad to the skin. Now, if we look at the three most important factors in determining seizure threshold, those are age, gender, and the electrode placement. But studies that have titrated everyone and then in retrospect done a factor analysis have found that those three factors only accounted for 40% of the variation between individuals in terms of their seizure threshold. And given that that still leaves 60% of variation not accounted for, this is why some clinicians advocate titrating everyone at the first session to determine their threshold. And you could also see why this would be particularly useful in a research protocol where you're comparing different energy settings, because you obviously need to know what the threshold is. Others would say that if you're going to multiply that unilateral threshold, say by 6, does it matter as much? Let's say the seizure threshold on unilateral is found to be 20% of the maximal energy the machine puts out, and you multiply that by 6, that gets you to 120%, and the machine only goes to 100%. So you're probably going to set the person either at the maximum or close to the maximum. So if that's the case, was there any advantage to titrating that individual? Or let's say you came up with a ballpark algorithm and you were off by about 30%. The question is, if you're not doing a research protocol, is that clinically relevant? Especially considering that when you titrate the person, you might have to give repeated stimuli. You get that vagal discharge, so you could get some bradycardia if you do that with the first treatment session. Maybe with that first treatment session, if you were just super threshold, once you found the seizure threshold, maybe that wasn't as good a treatment since the energy setting was at the bare minimum. And so others have advocated for just using an algorithm to estimate at that first session the seizure threshold. And the two main ways you could use a pre-selected dose is to do an estimate based on age, maybe being modified a bit up or down based on sex of the individual, as well as knowing what medications they're taking that session. So you could go a little higher or lower based on those factors. Or you could just pick, especially for right unilateral, a fixed high dose. Let's say you were going for 6 times threshold and the person only had a 10% energy threshold, so that would be 60%. And as I said, if they were 15-20% threshold, you're going to already be at about 100%. So you can imagine just setting the machine, let's say, for about 80% maximum. If you're doing unilateral, that would be called, if you did that for everyone, that's called a fixed high dose leads energy setting for right unilateral. So here's the seizure threshold, and as I said, what we would do is, let's say we titrate until we reach that threshold. Now, based on what I just showed you from the Sackheim study, you could either dose low dose, right, at 1.5 times threshold, or you could go about 2.5 times threshold. That would be considered a higher dose stimulation. So the idea would be that, let's say you were doing bilateral. Well, that study showed that there wasn't an efficacy difference between these two settings, but there could be cognitive side effects that are greater at this. So you would go to 1.5 if you're doing bitemporal. On the other hand, if you're doing unilateral, you would look at the seizure threshold, and then you would go to 2 to 3 times threshold. Now, the problem with doing that is, if you recall, there was a plateau effect after a few treatments for the people getting 2 to 3 times seizure threshold. Now, why might that be? Why didn't it keep going after that 40% response rate? Well, maybe it's because over time this seizure threshold went up to here. So you're not after a few treatments, at 2 to 3 times threshold anymore. You're just barely super threshold anymore. So if you were going to go to 2 to 3 times threshold with unilateral after a first titration session, you've got some options. One would be every 2 to 3 treatments, just go up a little bit on the energy, just on the assumption that seizure threshold is climbing some, and we're always trying to stay a little bit ahead of the game, so that a person might be titrated and find that they have a threshold of 10%. So if you were to multiply that, let's say by 6, or let's say we were doing 2 to 3 times threshold, you get to 30% energy stimulation. And after 2 or 3 treatments, you go up to 50. And after 2 or 3 treatments more, you go up to 70. So toward the end, you're getting to be at the maximal energy settings. But if what's important for side effects is how high the energy setting is relative to that person's seizure threshold, toward the end when you're going higher, it's not the same as if you had started that high from the outset. So that would be one strategy. Another strategy would be to look for biomarkers of whether the seizure threshold is going up. So if you're noticing that at the beginning, when you started at 2 to 3 times threshold, by the time the paper starts going showing the EEG, you have a good high amplitude seizure going and a nice clear endpoint with good postictal suppression of EEG activity. But as you progress over the course of treatment, you're starting to see some signs that maybe we're only just super threshold, like there's a slower buildup of the seizure and it kind of trickles out toward the end and the amplitude isn't as high. Maybe then, once we see that, we would, on the next session, go up some on the energy setting to go to a little higher than that. We can also ask patients, how is your mood doing? And if it seems like they were improving, but now their mood seems to be hitting a plateau, we could either go up on the energy setting if it's unilateral, or at that point think about switching over to bilateral toward the end of the course, right? Now, another thing that we could do would be, instead of doing 2 to 3 times seizure threshold to start and thinking about gradually going up, we could just titrate, let's say, and go to 6 times the threshold, so that even if the seizure threshold is now climbing, we started out at 6 times threshold, but by the end of the treatment course, maybe it's up here, we're only at about double the seizure threshold. But by starting so much higher, we don't have to worry about constantly falling behind in terms of adequacy of treatments. Now again, this is less of an issue with bilateral than with unilateral, because with bilateral, if you started out at 2 to 3 times threshold and by the end of the course you're only, say, at 1.5 times threshold, based on that earlier Sackheim study, you might not lose ground in terms of efficacy. So here's what I was talking about using the EEG. Let's say we stimulate and we just don't see a seizure. We see a little bit of slowing, but it doesn't look like we see a clear seizure, and we don't see any activity on the EMG, which is stuck on the foot distal to the blood pressure cuff. So we go up one step, and now we see this slow buildup of EEG activity, and then we wonder, are they seizing or not? But now the EEG kicks in. We are seeing some EMG activity, and now we do see clear spike activity. And then what we start to see toward the end of the seizure, the clinical seizure ends here at about 40 seconds, and then we start to see this breakup of frequencies, and we might be tempted over here to say, oh, maybe they've stopped seizing, but we keep the paper running a little longer, and we go, okay, now we are seeing the true endpoint, a nice sharp endpoint of EEG activity. But again, this makes us wonder if we're just super threshold. We see that they didn't seize until we went up on the energy, and you can see this slower build up. And if we went a little higher, we might see right from the time the paper starts that they're already going with a good amplitude right from the outset, and you see that clear breakpoint. And if it starts to resemble this EEG again, we might then say, well, maybe we should go up on the energy on the next setting. Of course, if I'm talking to the patient and they're doing great, why go up on the energy? We want to treat the patient and not just the EEG. Now, how would we titrate? Well, if you've got one of these machines that has 4 knobs, here you can see what we've done with this titration method is we've decided to keep the pulse width at 0.5 milliseconds throughout this tracing until we've maximized all three of the other possible settings. You can see that we've kept the current set at the maximum that this machine puts out, which is 0.8 amps, so that when we're initially going up, all we are doing to try to go up is either going up on the duration a bit, going up on the duration, going up on the duration here, then we went up on the frequency, then we went up on the duration. The goal is that in multiplying all of these together and looking at the charge or at the estimated joules, you can see that for each notch we're going up, we're about 1.5 times higher than the last setting. Right, so you can see here going from 32 to 48, or in this case 80 plus half of that would be 80 plus 40 gets you to about 120. Now you'll notice this is logarithmic, this is not linear. Going up one notch here, or let's look at estimated joules of energy. Going up one notch here is 1.5 times 5, which is only about 2.5, right? Going up here is going up 1.5 times 76 joules, which is like 35 joules, right? And so we're clearly going up much higher on the energy, going up one step toward the end parts of this algorithm than earlier. You also can see that this titration method is assuming that you will need less energy to start with a woman than with a man, and less energy with a unilateral lead placement than bilateral. So it's really unlikely that with a male and a bilateral lead placement you would even get a seizure at this setting. But for a female unilateral, we might. And so you could see here, female bilateral, we would start one step up, or male unilateral. So what we want to do is we want to have this table in front of us. We stimulate, we very quickly look to see if there's a seizure, and if not, we go up one step. So we're ready to go. We're ready to turn the knob and re-stimulate at that higher setting. If they still don't seize, we re-stimulate again at the next highest setting. And using this most commonly within 2 or 3 stimulations, the person should have seized using this algorithm for this table. Now you can see that is with the Mecta machine. This is the Thymatron, or the older Thymatron DGX machine, and you can see here we only have one knob, the energy knob, but inside the machine you still have these 4 settings. And you can see I've put here that using this machine, the pulse width is fixed and the current is fixed. And just like what we were doing manually, when we adjust the energy, we're adjusting the frequency of the pulses and the overall seizure stimulus duration. Otherwise, we're basically, again, doing the same thing. We go, here we're going 5 to 10, so that again is is a little higher than 1.5, but basically this is what we would be doing, is going up. Now, if we titrate and we get to a certain setting, and we were doing a bilateral lead placement, you could see that what we would do is go up by 1.5 if we were doing bilateral, so we would basically go up one notch at the next treatment session. If we were doing a right unilateral lead placement, we would want to go up 2 notches, right? Because our goal is to be 2 to 3 times seizure threshold, right? And you can see why they say 2 to 3, right? Because if I go up 2 notches from here, 100 is twice as much as 50. If I go up 2 notches here, 15 is 3 times 5. So basically it averages out to about 2.25 to 2.5 times seizure threshold when you go up 2 notches across this whole spectrum of possible settings. Well, here's another way that we could do it. Max Fink up in New York came up with this age-based dosing algorithm. And the idea here is that if you go set the machine at half of the patient's age in joules, that turns out to be just above the seizure threshold, about 1.5 times seizure threshold. Or if you set the machine for the patient's age in terms of the percentage energy, that will turn out to be about 2 to 3 times the seizure threshold, right? And just to kind of also show you, this is kind of interesting, that it just so turns out that the maximum energy in joules that the machine can put out is about 100 joules, and that turns out to be the same as 100% energy. And you can see here 5 joules turns out to be about 5% energy, so it turns out to be quite convenient that way. So basically, the idea would be, let's say you've got a 50-year-old patient coming in. If you are doing a bilateral lead placement, you would set the machine right here for about 25% energy, right? Or using the thymatron machine, again, you'd use about 25% energy, 25 joules for a 50-year-old if you're doing bilateral. On the other hand, if you were doing right unilateral and you wanted to be about 2 to 3 times threshold, you'd set the machine for here about 50% energy at the first setting. And that works out for the majority of cases to be about right. Now, you might underdose a bit. Let's say they didn't seize at that setting. Well, then you would just titrate up one notch, and you've spared yourself a few extra stimulations if that turns out that they really had, for whatever reason, a particularly high seizure threshold. Here would be another strategy, which is the fixed high dose strategy that I mentioned. Obviously, if you were doing unilateral, one strategy would be just set the machine for 100%. But the research that's been done on this has set the machine for about 70% of the maximal setting. And so about here, about 75, 70% of the maximal setting. So coming back to the Sackheim study, I said that there was a question that it brought up, and the question is, what if we added this extra group? Now remember, here's what he found in his original study, and I'm rounding up a bit here, that what he got was 17%, so about 20% efficacy for 1.5 times threshold unilateral, 40% for what he called high dose, 2.5 times threshold unilateral, and for both energy settings for bilateral, about 65%. And I asked in an earlier slide, what if we had 6 times threshold? So here's what it looks like now. So what did he find? Right? Here you can see he took 80 patients. It was a prospective double-blinded study, and he compared 1.5 times threshold versus 2.5 times threshold versus 6 times threshold unilateral. Now he didn't want to have so many cell sizes that you get into type 2 error, that you've got so many cell sizes that you don't find any difference between the groups because the numbers are too small. So he decided to eliminate one of these groups, and the group he decided to eliminate was this lower dose group. Now that's potentially problematic. If the main outcome measure is efficacy, and if his goal is to show that if the gold standard for efficacy is high dose bilateral, and if he can achieve efficacy with high dose unilateral that is as good as this high dose bilateral, that would be a good finding. But if you find an advantage for cognitive side effects of this group over this group, that doesn't answer the question, what about high dose unilateral versus low dose bitemporal? That's a question that's not answered here. But because his main issue here was efficacy, that's why he picked that setting. Again, just like his earlier study, he did a Hamilton Depression Scale and cognitive scores before the course, after treatment number 6, and immediately after his course, as well as 2 months after the ECT course. And responders, which was those with at least a 60% reduction in symptom scores 1 week after the course of ECT was completed, were monitored for relapse for 1 year. So what did he find? Here was his original findings, right? So let's look at what he found in the new study. Interestingly, between 1993 and 2000, when he did the new study, we were saying if you're going to use unilateral, definitely don't use low dose, use the medium dose, what's now being called medium dose here, 2.5 times threshold. He did not see a difference between these groups. But what he did see, it was right in the middle, 30%, right? But he did find he could achieve this 65% efficacy with the high dose unilateral, and that matched the efficacy of the higher group. And here's the curves, right? If you'll remember with the original study, this is what we were seeing. This was the unilateral, right? And again, what did he find in the original study was 60% relapsed, 59% in the next year. In the newer study, this is low versus medium dose unilateral. They're essentially identical curves. Here's the higher dose unilateral, and here's the higher dose bilateral. So again, almost identical here. In terms of recovery and cognition, again, he found that the bilateral ECT showed greater impairment than any of the dosages of unilateral, but that 2 months after ECT, retrograde amnestic deficits were improved in all groups. But you still did see greater deficits 2 months out in the patients getting higher dose bilateral treatment. The earlier study found that 59% of patients relapsed in the next year. Without group differences. And again, there were no group differences here. And very similar relapse rate, more than half, 53% relapsed in the next year. Was there a predictor of who was more likely to relapse? Well, greater relapse rates were found in those patients who hadn't responded to adequate pharmacotherapy prior to ECT, and those who had more severe depressive symptoms at the end of the ECT course. In other words, they were improved enough to follow them, to consider them responders and follow them for the next year, but they were not in remission.